This program is brought to you by Emory University.
Okay, good morning, everybody. Happy Friday. Welcome to another edition of Friday Journal Club. We have two speakers this morning. Our first speaker is Dr. Aparna Sajja. She is a third-year fellow in the clinical track. Aparna did her residency at Johns Hopkins, did a year of fellowship at Georgetown before transferring for family reasons here to Emory as a second year. And we've obviously been delighted to have her. She'll be staying on as an EP fellow next year. And she is going to talk to us, you'll see, about daily step counts and all-cause mortality. So take it away, Aparna.
Thank you, Dr. Williams. So yes, I'm going to talk about daily step counts as they relate to all-cause mortality and cardiovascular events. So I thought this was a funny cartoon, but certainly has some truth in showing that exercise is a form of medication, could be prescribed. So I'm going to be talking about the study from Jack that was published during October of last year. It looks at the relationship of daily step counts to all-cause mortality, cardiovascular events. So as background, we all know that regular exercise reduces the risk of cardiovascular disease and all-cause mortality in the general population, and that walking is an accessible type of physical activity. Daily step count represents an easy-to-use metric for the general population, and may have potential to improve physical activity adherence and outcomes. And there have been several prior studies that have shown that walking an extra 1,000 steps is associated with reduced risk for all-cause mortality up to 12 to 15% and lower odds of frailty. So the objective of this study, so this is a systematic review and meta-analysis. It examines the dose-response association of objectively measured step count metrics with all-cause mortality, incident cardiovascular disease in the general population. It also analyzes the effects of sex and step cadence. So in terms of the methods, the authors did a systematic literature search in PubMed and Embase from essentially inception to October 2022, using the search terms daily step count, step intensity, objective step measuring methods, mortality, and incident CVD. In terms of eligibility of the studies included were those that quantified daily step count using objective step counting methods like accelerometry or pedometers, those that examined the associations between step count and all-cause mortality or incident fatal or non-fatal cardiovascular disease, those that had a prospective cohort study design, those that were peer-reviewed, and finally, adults more than 18 years of age without cardiovascular disease at baseline. They excluded those with congenital heart disease. And then in terms of the data extraction and quality assessment, there were two independent researchers who selected the studies. They discussed the results to reach consensus, and if there was disagreement, the consensus was reached by consulting a third researcher. There were categorical dose response analyses performed for step count and cadence, and then there was also a continuous dose response analysis. So basically, they looked at high and intermediate and low step category counts and cadences and compared. And then they also looked at various types of measuring devices and where they were placed, like hip-worn accelerometers, pedometers, wrist-worn accelerometers, and then looked at the interplay of cadence and step count. So this is a flow chart kind of showing they started off with 5,414 potential studies that were identified. And then of those, 1,078 were duplicates. So 4,307 papers were excluded just based on the title and abstract. So that basically left, in the end, 29 papers that were screened for eligibility. 15 didn't meet the inclusion criteria, and then 2 were excluded due to insufficient data. So in the end, 12 were included. 11 looked at the association between step count and all-cause mortality. 4 in particular looked at step count and incident cardiovascular disease. 4 looked at step cadence and all-cause mortality. So with the results, in the end, they looked at over 111,309 individuals. 61% were women. The mean age was 63 years, mean BMI was 27. The mean daily step count was 7,069 steps. The step count was quantified using pedometers, hip-worn or wrist-worn accelerometers, and all the studies measured step count for 7 days except one cohort. Looked at it for 2 days, and then 4.4% of patients died during median follow-up period of 78 months. So this here basically shows that the intermediate step count, so say a median of 6,000 steps, were associated with significantly lower mortality risk with an adjusted hazard ratio of 0.64 compared to the lower tertile, which is a median of 3,166 steps. So for each study, the black vertical and horizontal lines, they represent the effect estimate and 95% confidence interval. The red diamond is the pooled estimate and the 95% confidence interval. And of note, the I-squared here is 53%, which it's a pretty heterogeneous sample, so take it for what that's worth. And here, this is the risk reduction for association with all-cause mortality, showing that that was largest in individuals with the highest tertile, so a median of 10,000 steps per day with an adjusted hazard ratio of 0.5. And then the I-squared here is 62%, so again, a very heterogeneous population sample. So individuals in the intermediate median of 5,737 steps and the high median of 11,000 steps had a lower risk of incident cardiovascular disease compared to the low step count tertile, which was 2,000 steps. And then they also, so this is just kind of summarizing the highlights of their study. Basically, risk reductions were statistically significant for associations with all-cause mortality at a minimum of 17 steps. And then cardiovascular disease, you saw that at 2,735 steps. They looked at a total of 1,224 individuals, so 1.4% of the population developed cardiovascular events during the 73 months of follow-up. And we see that the dose response curves here are nonlinear. They show nonlinear trends for associations between step count and all-cause mortality, incident CVD. So we saw further increase. It shows that there's further increases in step counts were associated with decreased mortality up to a certain point. So 8,763 steps here for all-cause mortality, and then 7,126 steps for incident CVD. And so, at a certain point, more than 16,000 steps, there was no additional benefit really. And this again shows dose response curves for daily step count, all-cause mortality. The minimum dose statistically that was significant enough to reduce the risk of all-cause mortality was 3,155 steps here for men, and then 2,864 steps for women. And the optimum dose, which was defined as the maximal risk reduction at the least effort, was established at 6,700 steps for men, 7,690 steps for women, respectively. So, and then they also looked at the hip-worn accelerometers. They showed that these were associated with more pronounced mortality risk reduction than studies with wrist-worn accelerometers and pedometers. And then looking at the cadences, which is interesting. So 63 steps per minute, which is defined as intermediate cadence, and then high cadence of 88 steps per minute were associated with lower risks of mortality than the low cadence group. So this is looking at a heat map of the interplay of different step count volumes with all-cause mortality. So green is going to be significant reductions in risk. And then red is going to be significant increases in risk. Gray is going to be no significant differences compared to the reference level. So changes in risk estimates following increasing or decreases of 1,000 steps per day were strongly dependent on the baseline step count here. And then this is looking at different step count volumes with cardiovascular disease risk. So in essence, the highlights of the study, there is a dose response association of daily step count with all-cause mortality and incident cardiovascular disease up to a certain point. The minimum doses of 2,500 steps were associated with an 8% reduction in all-cause mortality, around 2,700 steps with an 11% reduction in cardiovascular disease risk in the study. And then we have optimal doses for 60% reduction in all-cause mortality being 8,700, and then 7,000 steps for incident cardiovascular disease risk reduction of 51%. And then increasing from low to intermediate and high cadences was also associated with decreased in all-cause mortality risk, 33% versus 38%. And there were no important differences in risk reductions with step counts between men and women. And really, the additional mortality benefit with higher cadence in the study certainly makes sense, it being a proxy for fitness, higher cadence, more oxygen consumption. However, most of the mortality benefit here with the cadence came from just one study, where the other 3 studies that evaluated the cadence did not produce statistically significant results. So really, the study focuses on steps per day more than the message of the cadence. And this really kind of follows along results from prior studies in terms of step count or bare minimum, with still some benefit in mortality and cardiovascular risk. So there was a JACC study in 2014 that looked at 55,000 people over the age of 15 and looked at 42,000 non-runners and then 13,000 runners. And they all had reductions in mortality and cardiovascular mortality of 30% and 45% compared to the non-runners. And even in the lowest quintile of running, so 1 to 2 times a week, less than 6 miles a week, had similar all-cause and cardiovascular mortality reductions compared to the higher dose runners, which is interesting. And then there was a study from Lancet in 2011, which looked at over 400,000 participants in Taiwan. They were followed for 8 years, and only 15 minutes of physical activity they found per day was enough to produce some form of mortality reduction. And then every additional 15 minute of exercise beyond the minimum of 15 was associated with reduced all-cause mortality by 4% and all cancer mortality by 1%. So there are certainly a lot of limitations to this study. The strength being it's a very large sample size, but it is a meta-analysis of a bunch of studies with each having their own individual source of error, and then when they're lumped together, they're going to have even greater error. Of note, I think, so only 4 of the studies looked at the additive effects of step cadence to total step counts. The daily step counts were investigated only at baseline, but physical activity behavior, of course, may change over time. The findings may not directly be extrapolated to chronically diseased older populations, certainly. And then the adjustments for the confounding variables were certainly interesting. For the adjusted hazard ratios in the supplement, it looked like various studies adjusted for various things. For instance, some adjusted for age, sex, education level, weight status, number of self-reported illnesses at baseline. Others looked at geographical region, season of wear time, social class, alcohol intake, BMI, mobility. So of these, different things were adjusted in various studies, and certainly association is not causation, which they showed in the study. Step count is associated with decreased mortality after adjusting for these variables, but they may be mediated through other effects of step count on blood pressure, cholesterol, fitness, etc. And then, of course, what was defined as low, intermediate, and high step counts was set by each individual study. So what may be high in one study may be an intermediate and a low. So I think that was also a potential huge limitation. But I think the message still has some degree of truth in it. In the era of new and popular medication, it really highlights the understated cardiovascular benefit of simple exercise like walking that's accessible to the majority of the population across various socioeconomic statuses, across several chronic diseases. And I think we as physicians can motivate our patients to increase activity with at least 1,000 steps, which would be achievable through about 10 minutes of activity. That's it. These are my references. I'll happy to take any questions as well.
Thank you, Aparna. Yeah, I mean, you sort of touched on, I guess my question would be, and you sort of hit it, but maybe you can go a little bit deeper, like applicability, obviously in a young, healthy sort of preventive population, because a lot of times patients will ask you for very specific recommendations in terms of how many steps or how long should I exercise, and even like what types of exercise, that sort of thing. So I think this gives you can give people sort of general recommendations, but for our older populations or sicker populations, how would you what would be sort of your advice, say for like I said, someone in their 70s or 80s who's still looking to be active, but may not be able to achieve, 8,500 steps a day or something like that.
Yeah, absolutely. I was just thinking of this at the VA clinic where a lot of them have issues with mobility and they certainly can't even, attain 2,000 steps a day. I think any other kind of physical activity, whether that's like water aerobics or even like a stationary bike, would in some forms, achieve whatever this step count goals, similar risk. I think any activity is good, I think, is the bottom line. And then even an additional 1,000 steps can be helpful.
Agreed. Yeah, I mean, that's sort of how I'll advise them. I'm just like, whatever it is you can do, just that you're doing something, 30 minutes, 4 times a week, something like this, or just a little bit of something every day, just to increase that, whatever your baseline is, increase it by a certain amount. So other questions, comments from the group?
Aparna, Stan Sherman. I think that 15 minutes a day was what you finally decided on. Is that right or wrong?
Yeah, I think that was actually from a prior study that I was, showing as reference. The one study from, I think, Taiwan, where each additional 15-minute was associated with a, reduction in risk. This study is basically saying that you don't need 10,000 steps a day to, achieve benefit. Optimum doses being around 8,000 steps.
All right. Well, very good. Thank you, Aparna. Appreciate your work. And we'll switch over now to Aggie Karagiannis, another third-year fellow in the clinical track. He's originally from Mississippi. I'm kidding. Greece. We actually, before we switch over to Aggie, we did have a question come up in the chat that I just noticed. How many people here get 8,000 steps a day on average? Oh, more audience response. During her talk, I actually pulled up my thing. Yeah, barely. I'll just say personally, I barely get it, but just barely. But it's a good goal. Yeah, probably. Yeah, it depends on if I'm on service or not. When I'm on service, I definitely do. All right. So everyone check your phone, see, there you go. Nice, Rob, way to go. All right, Aggie from Greece, did medical school in Greece, came to Emory for his residency. Go ahead and make it full screen there, Aggie. Did his residency here at Emory. He will be staying on next year as an interventional fellow. And looks like we're gonna have a political discussion this morning. No, we're gonna talk about transfusions. So take it away, Aggie.
Thank you so much, Dr. Williams. Good morning, everyone. Happy Friday. I'm excited about our today's talk. So we all encounter patients that present to us with acute MI in the hospital, and then they also have anemia. And there is this question on whether giving transfusion and when shall we give transfusion to achieve like the best cardiovascular outcomes for this patient. There is a huge vacuum in terms of evidence when it comes to these patients, like acute MI and a hemoglobin threshold for transfusion. So that's why today I'm going to talk about the most recently published trial on this topic. It's called the MIN trial. It's a very big trial, which tries to give us an answer what we should do with these patients. And we might end up having an answer, or most likely we won't. Actually, we'll see. So let's start with a brief history here. So as far as transfusion history, so the first human transfusion, blood transfusion, was actually happening in Philadelphia in 1795 by American physician called Dr. Physic, which has a great name for a physician. So although this actually blood transfusion was not recorded, this figure here is from the first recorded, like published transfusion from a British guy called Dr. Blundell, who actually transfused like blood from the husband to the dying wife that she was hemorrhagically, she was hemorrhaging peripartum. So in 1937, Bernard Fantus over at Cook County Hospital in Chicago was the first one to establish a blood bank in the United States. And almost like 80, 90 years later, today in the United States alone, we actually transfuse like 16 million RBC units annually to 3.4 million patients. So there's a huge growth in terms of transfusion and the daily use of RBC unit transfusion. So as we know, it has been established that a patient is anemic if has a hemoglobin value of less than 13 for men and 12 grams per deciliter for non-pregnant women. So it comes with no surprise that when, up until like 1990s, we used to transfuse very liberally to at least try to achieve this level. So like, although there wasn't a universal cutoff, hemoglobin cutoff back then, most of the physicians would try to achieve like of at least a 10 grams per deciliter cutoff, like before they start transfusing patients. Until there was this brave trial, considered like about like starting like trying to transfuse like patients with a lower cutoff, whereas all the other people were transfusing like, to achieve like a cutoff of 10. So this trial, the seminal TRIC trial, actually challenges the then standard practice of liberal transfusion. And what it showed is that in critically ill patients, there was no significant difference in the 30-day mortality among those patients that they got like more of a liberal transfusion strategy, like to achieve a hemoglobin cutoff of 10, versus a more restrictive strategy for a cutoff of hemoglobin of 7 before they get any transfusion. And a quote from the study is that these results apply with the possible exception of patients with acute myocardial infarction and unstable angina, where there is these patients were included given the the fear that actually they will do worse if we are restrictively only transfusing them. So these TRIC trials spurred, as a result, many more trials of similar design that they were investigating whether or not different populations with diverse diseases will actually benefit from a restrictive versus more of a liberal approach when it comes to transfusion. So they tested like patients with acute GI bleeding, patients undergoing orthopedic, vascular, or cardiac surgeries, and then collectively all these trials reached to almost the same kind of conclusion that a restrictive transfusion strategy was actually safe, and also consistently it would confer clinical outcomes that they were similar or even better than the liberal strategy. And as a result, we now have moderate to high quality evidence to support an adoption of a hemoglobin threshold of 7 or 8, depends on some populations, to trigger transfusion. Without surprise, here are that the 2023 AABB International Red Blood Cell Transfusion Guidelines came up with this recommendation that for the hospitalized adult patients who are hemodynamically stable, the cutoff for transfusion is when the hemoglobin is less than 7. And there's strong recommendation and moderate certainty evidence for that. However, they add, due to insufficient evidence, no recommendation for transfusion threshold for patients with acute and chronic ischemic cardiac disease. So when it comes to a cardiac, when it comes to a patient with ischemic heart disease and transfusion, there are two groups of people that they can support either way. Like the first group would say that we have an ischemic myocardium, and then blood transfusion will improve oxygen delivery to this myocardium, and therefore will decrease an ischemic injury and reduce the risk for reinfarction or even death. Whereas the other group might say more blood could result in more frequent heart failure in this ischemic struggling myocardium and more fluid overload. And then, although the risk right now for an infection or inflammation due to a transfusion is lower, still exists. Also, interestingly, the cost of one unit RBC is not actually something that we can consider. Like a unit of RBC usually costs from all the way from 500 to 1100, when with a mean average of like 600, excuse me, dollars per unit. And obviously, we also have like a significant shortage of RBC, so it's a very precious commodity, I would say, that we don't want to go and spend around. So we before this trial, we actually had a conflict. So we had like several observational studies and small RCTs trying to see what we should do with these patients with MI and anemia. And all of them almost came to different conclusions with conflicting data. Some of them, favoring the liberal strategy, some of them favoring the conservative strategy. And then, as we discussed, like there are pathophysiological arguments that can be made for either or. And so far, all the guidelines, transfusion guidelines, including the one that I showed you, provide actually conflicting advice. So there is insufficient evidence overall to determine a hemoglobin cutoff level for transfusion in patients with ischemic heart disease. And the question emerges, when should we transfuse a patient with ischemia and anemia? And this is something that we again encounter many times. So it's something that we should seek an answer for. And that's exactly what the MID trial tried to do. This recently published trial, just by the end of December, like 2 months ago, actually tried to investigate whether or not a restrictive versus a liberal transfusion strategy in myocardial infarction and anemia patients would actually confer any benefit for the liberal transfusion strategy. So in regards to the trial's population, first of all, it was a big trial for transfusion standards. Like a total of 3,506 patients were enrolled from many sites across the world. Countries that participated were United States, Canada, France, Brazil, New Zealand, and Australia. All participants were adults, all of them over 18 years of age. And then for a person to be enrolled in these trials should present with either STEMI or an NSTEMI and be anemic with a hemoglobin of less than 10 grams per deciliter. So these patients would have like either type 1 MI, type 2 MI, or type 4B, like this is an instant thrombosis, and or 4C, instant restenosis myocardial infarction. And there was some exclusion criteria, mostly were the patients that had uncontrolled bleeding, or the patients that were receiving palliative treatment, and or the patients that actually had planned or scheduled for a cardiac surgery during the current admission. So this is the design. It's relatively simple. So the patient presents with acute myocardial infarction and was found to have a hemoglobin of less than 10 grams per deciliter. So these patients were randomly assigned in a 1-to-1 ratio in 2 different groups. The first group was the restrictive strategy group, where pretty much patients would not get any transfusion unless their hemoglobin was less than 8, and that was like permitted, or like further recommended if it was below 7. But overall, our patients were actually having like anginal symptoms, uncontrolled. But overall, like a patient wouldn't get any transfusion if their hemoglobin was below 8. And then the liberal strategy group is that the moment these patients were randomized to this group, they would immediately receive 1 unit of blood, and then they would receive transfusions in order to maintain a hemoglobin of more than 10 grams per deciliter. Overall, this trial lasted for 30 days. And then its outcomes it had like primary, secondary, and other outcomes. As far as the primary outcomes, that was a composite of myocardial infarction or death from any cause. And then the pre-specified secondary outcomes were like individualized the outcomes of the first primary one, so myocardial infarction, death, and then the composite outcome of death, MI, coronary revascularization, or readmission to the hospital for an ischemic condition. So in regards to the baseline, I think they did a pretty good job on kind of like randomizing people. Like, although they don't have any kind of statistical significant difference, like next to each characteristic to see if there's any actual difference. Overall, it looks like they did a pretty good job randomizing them. And then some baseline characteristics that are notable is that the mean hemoglobin, the pre-randomization level was 8.6. There was a 45% female percentage of the participants, and 70% of the patients were white. Patients were actually sick, like they had very frequent coexisting illnesses. 65% of the patients had multivessel coronary artery disease, 22% of the patients had CABETs, and 30% had heart failure. As far as the presenting MI, 81% of the patients presented with an NSTEMI versus 19% presented with a STEMI. Here, I would like to say that in the protocol, they categorize the MI as a STEMI or an NSTEMI. So it's not like they have the NSTEMI only as a type 1 MI. And then as far as the types of the MIs, 42% was type 1, 56% was type 2 MI, and the rest was like 4B and 4C. Some first results from this trial, first of all, it showed that actually, as expected, the patients in the liberal group, they had higher hemoglobin than the patients in the conservative restricted group. So both in day 1 and day 3 that were measured, in day 3, eventually they ended up having like 10.5 mean hemoglobin, the liberal group versus 8.9. And that was statistically significant. Overall, like the liberal group got like 4,325 units of RBC versus only 1,237 units in the restricted group, and that was 3 times higher overall. And then the mean number of RBC units that were transfused in the liberal group was 2.5 versus 0.7 in the restricted group. And then the median duration of hospitalization was similar between these two groups, around 5 days. In regards to the primary outcome, so there was a trend favoring the liberal group. And interestingly, in the liberal group, there were like 255 out of the patients, and overall like 14.5% of the patients in the liberal group that had an event versus 16.9% of the patients that had an event in the restrictive strategy group. And even though that was like not statistically significant, that was like literally only few events away from becoming statistically significant. So the risk ratio was like 1.15 favoring the liberal strategy group with a confidence interval of 0.999 to 1.34. As far as the secondary outcomes, again, there's a trend favoring like the liberal group versus the restricted group. And in terms of the death, the liberal group had like 8.3% versus 9.9% of the restricted strategy group that had death. And then as far as the MI, again, 7.2 in the liberal group versus 8.5 with a confidence the risk ratio of 1.19, confidence interval of 0.94 to 1.49. And lastly, for this composite secondary outcome of death, MI, coronary revascularization, and ischemic cardiac condition, again, a trend favoring the liberal group with 17.4 patients having these events versus 19.6, and with a risk ratio of 1.13, with a confidence interval of 0.98 to 1.29. We also had some other outcomes pre-specified that among these outcomes, I would like to focus on one, and this is the cardiac death. So if you see here, specifically for cardiac death, there was a statistically significant difference between the liberal and the restrictive strategy group. Interestingly, the liberal group had 3.2% of cardiac death versus the restricted group had 5.5, with a risk ratio of 1.74. So, and then another event like that was interesting is that I would expect that the heart failure, like in the liberal group, getting all this extra transfusion might have an increased heart failure, which it wasn't the case. In the heart failure, I would not. There wasn't any difference between these two groups. So they also did some subgroup, pre-specified subgroup analysis. And then I would like to highlight two groups from here. The first one is the type 1 MI patients. So these patients actually also show that they benefited from a more liberal strategy. So 18.2% of the conservative strategy group had events versus 13.8 on the liberal strategy group when it comes to type 1 MI patients. And also there was no difference among patients with type 2 MI. So another category that actually did better with the liberal group, it was the patient with a history of congestive heart failure. So that also had a risk ratio of 1.25, and that was statistically significant. In regards to the side effects, so there were actually more tackle, transfusion-associated cardiac overload events in the restrictive versus the liberal strategy group, and that was statistically significant. But however, as we discussed, the risk of heart failure at 30 days was not different between these two groups. And also there was, as expected, more events of febrile non-hemolytic transfusion reaction in the liberal group that got more transfusion. This study was overall well designed. However, there were some limitations. Obviously, it wasn't blinded. Patients knew when they got transfusion. Providers knew when they were providing transfusion. And then they had a relatively good but not perfect kind of adherence to the hemoglobin threshold in the liberal group. So only 86% of the people on the liberal group were able actually to achieve more than 10 grams of deciliter of hemoglobin upon discharge or by the end of the trial. And then actually this trial wasn't adjusted for multiplicity. So they say that the caution must be used in interpreting any results beyond the primary outcome. So overall, the main trial showed that in patients with acute MI and anemia, a liberal transfusion strategy did not significantly reduce the risk of recurrent MI or death at 30 days. However, the liberal strategy was consistently favored in primary outcome, in death, in recurrent MI, and in cardiac death, and in secondary outcomes too. And here's some final thoughts that I got out of this trial, is that, again, although a negative trial, there's a consistent trend towards better cardiovascular outcomes in the liberal group that does warrant some further attention. So I was wondering if that trial would be positive only if type 1 MI patients, like patients with, a plaque disruption only, actually were included in this trial, given the fact that in this specific subgroup, results were actually pretty impressive. And then obviously we know that a liberal transfusion to all the patients with acute MI is neither cost effective nor necessarily beneficial. However, I think we should try to identify this specific individual or specific subgroup that might benefit from a more liberal approach. And then personally, what I got out of this trial is that unless there's any contraindication, I totally now feel more confident about aiming for a hemoglobin cutoff of at least 8 milligrams per deciliter in patients presenting with type 1 MI. So, I mean, I know that in our hospital, obviously we try to do only as when we see less than 7, but I think we have the data to be more confident about aiming for at least an 8 to trigger a transfusion. And if there's any new trial coming that might enroll only type 1 MI patients, I won't be, surprised if we eventually have a higher cutoff for this specific population. So thank you so much, and I'm open for questions.
No, thank you, Aggie. That's a beautiful picture of Mississippi there. I guess my question is, how will this change your practice at all moving forward now that you've reviewed this?
Yeah. Yeah, it's like someone would say, we spend this trial literally spent millions of dollars to try give an answer, and then the answer wasn't necessarily given. And then would that, after all these years of this trial, all this population, does this have any impact on our clinical decisions? I would say based on that, based on my last statement, that yeah, I mean, right now, I truly believe that I would, whenever I see type 1 in my patient, like with a acute coronary, with a STEMI or an type 1 end STEMI, and I see hemoglobin of 7.5, like up until I read this trial, I wouldn't necessarily jump into giving a blood. But now if I see a 7.5 on a STEMI patient, and then that is otherwise hemodynamically, stable, no congested heart failure and stuff, I will go ahead and give the blood. I mean, I think it was a pretty significant difference between type 1 MI patients, between the liberal group and the conservative restricted group.
Yeah. So you'll be slightly more liberal, but maybe not a hard line.
Yes.
Questions from the group?
Yeah, Aggie Stan Sherman. Was there any differences or anything about whether they underwent revascularization during these hospitalizations in terms of these outcomes?
Yeah, wasn't a statistical significant difference between for revascularization, but again, there was some trend favoring the liberal group. So liberal group patients tend to have less revascularizations, but again, not statistically significant there.
Hey, Robbie, good morning.
Morning.
So this is Dan Vierab. So this is an interesting paper, but from the interventional perspective, it's a negative quality metric for us to transfuse anyone after PCI. And one thing that this article might do is maybe to change NCDR to think that transfusion is okay and is not a bad metric to have. This is very different from procedural bleeding where you get transfused. And again, in patients with non-STEMI, you may just have a little time to transfuse this patient before you actually go into PCI. So I think the article might change. Obviously, subgroup analysis of this trial is going to come out in ACC 2024, and there'll be more data to come. But I don't think we can now be very strict in our transfusion requirements based on this particular trial, that perhaps it's okay to transfuse these people above 7, get them closer to 10 if possible, post-PCI and acute primary PCI STEMI. So I think that is the one big take from this article that I have.
Yeah, I'd echo that. I think it's an important statement. It's just that, right now, like many things in the quality improvement initiatives, sometimes quality is not necessarily true quality. And so we have to be cautious, I think, how we interpret some of the our quality data, because right now this, the transfusion post-MI is considered a complication, and it's also a treatment. And so those two things are at odds, and hopefully we can sort this out at the ACC level. But right now, from a practical standpoint, we have a treatment that may have some benefit that's also considered a complication. And it's just the controversies that we live in with our quality data.
A couple people have their hand up. Sorry to interrupt. Dr. Dicker, you had your hand up.
Yeah. So I just wanted just a couple thoughts. One, I think, is the importance of being really careful when we describe things as significant and non-significant. Right. This is a p-value of 0.07. That is a very marginal difference from a p-value of less than 0.05, and everybody would be holding their hands up and calling it clearly positive if it were less than 0.05. I think it's really just critical to recognize that that is not the difference between knowledge and not knowledge. So I think, I think Aggie mentioned this, but I think it's important to recognize all the endpoints sort of moved in the same direction. I think this is just a question of they presented this when they presented this as a late breaking trial at AHA. I forget the number, but they talked about if they had basically, I don't know, was it 40 more people in the trial, it probably would have been positive from a p-value of less than 0.05 perspective. So I think it's really important to recognize the arbitrary difference there. And I would consider this a positive trial with a maybe not quite the effect size that they had hoped for. The other thing I would say is, Aggie, I would sort of think a little bit differently in terms of who this is likely to benefit most. If we think of the population that is likely to benefit, I think it's the sicker people. And to me, one of the most helpful subgroup analysis was in the group with heart failure, probably one of the only subgroups that was statistically significant. Again, these are subgroup analyses, but they were pre-specified, is in the patients with heart failure. And so what I take away from this trial is that in patients, particularly ones who we think might be struggling, there's probably the strongest reason for targeting higher hemoglobins in that patient population. If you have a very straightforward patient who comes in, now granted, many of these patients are not anemic, but super straightforward MI, who gets revascularized very quickly, my guess is the benefit in that population is staggeringly small. If you have a patient, on the other hand, with complex disease, who's not doing well, to me, that's the population that likely benefits. I think this trial sort of supports that notion. The other question that you get at in terms of what the target, it's just always important, right? They did a 7 or 8 versus 10. We have no idea whether 9 is just as good as 10. We have no idea whether 8.5 is okay. It's hard. It's really hard to set sort of cutoffs for ourselves, and we always have to do it because we have to decide when to pull the trigger. But I think it's important to recognize we don't know how good the middle is, and I think it'd be interesting to see if they can come up with some subsequent trials that start to tease apart whether there's any clear cutoff, and there may not be, but kind of what we are certainly left with. We have a zone within which we have some data, but we don't have precise targets.
All right. Any other questions?
Well, one other thing, Robbie, to point out is that this trial did not really look at patients with chronic kidney disease and the benefit of transfusion in that group. That's a whole big population for us, okay? So when people come in with CKD on hemodialysis and have hemoglobin of 7, we are unclear, pretty based on this trial, whether they would have any benefit or not, okay? So that's important to point out.
It does. There is a subgroup analysis there, Tanvir, that's on the screen that there was a population. The lower the EGFR, the stronger the signal.
Yeah, but I think I don't think there was
all points towards the sicker the patient, the more likely they are to benefit.
Yeah, I'm not sure. Really, looking at the article, the way I interpreted it, that the renal group had that much of a benefit, But we'll see what the ACC data shows on this coming April on the subgroup analysis for further, that they're going to present.
All right. Well, thanks again to everybody for tuning in today. And thanks again to our speakers, Aggie and Aparna, and look forward to seeing everybody next week.
The preceding program is copyrighted by Emory University.